Thank you, Mr. Chairman. Dear colleagues, I would like to thank the organizers for inviting me to participate in this important symposium. And I will try to discuss the next 15 minutes the ways that we know to overcome hyporesponsiveness to Clopidogrel. It has been 10 years since the description of this phenomenon from this very important work by Pragugrel in Baltimore, where he described the variable response that is observed in patients receiving Clopidogrel. Apparently, subjects that are in this part are the ones that have low response to Clopidogrel and are considered hyporesponsive. We heard in detail about the previous speaker on the importance that the high hyporesponsiveness to Clopidogrel has in predicting events after an acute coronary syndrome and the PCI. And I will repeat only the fact that from this analysis was shown that subjects in the upper quartile of platelet reactivity have almost 3 times more the event rate than those in the lower quartile. This is an important slide in order to understand why and we're using other antiplatelet agents in order to overcome hyporesponsiveness to Clopidogrel. Clopidogrel is metabolized in a rather complex way involving 2 metabolic steps in the liver, and several cytochromes are involved in the metabolism of Clopidogrel, and the integrity of function of these cytochromes is important in order to have adequate levels of active metabolite and subsequently adequate action of Clopidogrel. Pragugrel, on the other hand, is still a thienopyridine, but has a simpler metabolic activation in the liver. So it's rather predictable, the amount of active metabolite that is presented to the receptor itself. And finally, Ticagrelor is the third player in the game, is in a way bypassing the liver. It acts directly on the receptor, on the P2Y12 receptor. And in fact, this happens because Ticagrelor is a drug itself. It's not a pre-drug. Part of Ticagrelor involves, undergoes metabolic activation in the liver, but this is not a necessary step in order for Ticagrelor to express its metabolic action and activity. It was described quite well a couple of years ago that the CYP2C19 locus is the sole locus thus far associated with Clopidogrel response variability. So we all know that this is a kind of marker that for Clopidogrel hyporesponsiveness. However, the dysfunctional allele at this locus is responsible only for the 12% of the variability in Clopidogrel response. Let's go through several clinical situations in which we have studies about the ways to overcome Clopidogrel hyporesponsiveness. The most well-studied situation is the patient following acute coronary syndrome who undergoes PCI. The most logic and similar way to overcome Clopidogrel hyporesponsiveness is to double the dose. And this is what was tested in this study 4 years ago by a French group, showing that doubling the dose is effective, but not much. Still, following doubling the maintenance dose, there is a considerable proportion of patients that still has hyporesponsiveness. This was the basis for what we had before, the GRAVITAS study, which was a rather disappointing study, in which patients with PCI and DS were stratified if they had a high platelet reactivity greater than 230 to either standard therapy or tailored therapy, another 600 milligrams of Clopidogrel plus double Clopidogrel maintenance dose. There was no difference in outcome in this trial, and the most accepted explanation that is given is that it involved rather low-risk population. The event rate was low, plus the way that they tried the authors to overcome Clopidogrel hyporesponsiveness by doubling simply the dose was not very efficient in reducing platelet reactivity. Another approach had been to try to overcome Clopidogrel hyporesponsiveness acutely by giving repeated doses, loading doses of Clopidogrel. Mainly the work from the group in Marseille has been done, and you can see here that in patients they were given up to 2,400 milligrams of Clopidogrel with good result, of course, and in this rather small study, the tailored approach with repeated loading of Clopidogrel was followed by better outcome. Another approach is not to target Clopidogrel hyporesponsiveness, but to target genetic resistance. In other words, this study with different loading dose of Clopidogrel did not look at patients with Clopidogrel hyporesponsiveness, but looked at patients who were carriers of the dysfunctional allele. And they found that if you are heterozygote and you increase the loading dose from 300 milligrams to 900 milligrams, then you have a good effect, but this approach does not work if you are homozygote. And this was supported also in the long term in the Elevate TIMI56 trial that there was a question on it just 5 minutes ago, showing that if in heterozygotes, if you triple the Clopidogrel dose up to 225 milligrams, then you may achieve a platelet reactivity similar to what is achieved by the usual dose in non-carriers. But this approach has no effect in homozygotes. So we looked for other ways. We looked for the use of other antiplatelet agents like Pragugrel in this very first study by the group in Paris, where in 6 patients with clinical Clopidogrel resistance, namely Stent thrombosis, they tried increasing Clopidogrel dose with no effect, but the addition of Pragugrel was effective immediately to reduce platelet reactivity in these cases. We did a study comparing Pragugrel with double Clopidogrel dose in patients who had high platelet reactivity following PCI. And Pragugrel was in green was much more effective than double Clopidogrel in reducing platelet reactivity. And this difference was very more prominent in carriers. In carriers, doubling Clopidogrel has minimal effect. So it's a loss of time to try to overcome it in carriers. It's better, it's much better and more effective to switch to Clopidogrel. The individual values from these patients, you can see that following doubling Clopidogrel, a considerable amount of patients still have hyporesponsiveness to it, while minimal, very few patients have high platelet reactivity following Pragugrel. In clinical practice, this approach was tested in the Trigger PCI trial, where patients with high platelet reactivity post-Clopidogrel were randomized to either Clopidogrel maintenance dose or Pragugrel maintenance dose. And of course, giving Pragugrel in blue was effective in reducing platelet reactivity, much more than Clopidogrel. However, in the clinical outcome was similar between the two arms because the event rate was very, very low. So it was a low-risk population and almost impossible to demonstrate any difference. The third player of the game, the newer one, Ticagrelor, is a very effective agent because it's a direct acting. And from this platelet sub-study, you can see that almost no patient presents with high platelet reactivity following Ticagrelor. We presented recently our study comparing Ticagrelor versus Pragugrel in acute coronary syndrome patients with high on Clopidogrel platelet reactivity following PCI. We randomized 44 patients who had high platelet reactivity to either Ticagrelor or Pragugrel, and we found that Ticagrelor produces stronger platelet inhibition. The platelet reactivity is lower than Ticagrelor, than Pragugrel. However, both agents effectively treat high platelet reactivity. Just to mention that in countries outside Europe and US, mainly in Asia, another agent has been tested to overcome hyporesponsiveness to Clopidogrel. Silostazol is a phosphodiesterase 3 inhibitor with results from the axial resistance study in patients with Clopidogrel hyporesponsiveness. Using silostazol, the triple group therapy had a better effect than the double antiplatelet therapy. In another setting, chronic CAD patients, then the data are fewer. We looked at the patients who received at least 6 months Clopidogrel and tried to identify if they had high platelet reactivity. And those that we identified, about 1/3 of patients, we randomized to either Pragugrel or double Clopidogrel. The results were similar with the acute coronary syndrome patients. Not much of effect by doubling Clopidogrel, but very efficient action of Pragugrel. In such patients, the Ticagrelor has been shown to effectively eliminate HPR from the pooled data from the respond and offset studies. And let's move to a very interesting clinical scenario, the STEMI patients. STEMI is a different story. We have described recently that there are several factors influencing the platelet reactivity following Clopidogrel in STEMI. And in this study, following 600 milligrams loading of Clopidogrel, we identified that the upstream Clopidogrel loading and the presence of renal dysfunction were factors affecting the presence of hyporesponsiveness to Clopidogrel. You can see that following Clopidogrel loading, 600 milligrams of Clopidogrel in STEMI, 2/3 of the patients at 2 hours later presents high platelet reactivity. And these 2/3 in this study were randomized to either double Clopidogrel or reloading with Pragugrel. And what we found is that 2 hours following Pragugrel, there was still a considerable 40% of cases with high platelet reactivity, but at 24 hours, almost everybody responded to Pragugrel. The results were not so good for Clopidogrel in STEMI. Even at 5 days, 1/3 remained hyporesponsive. Finally, another interesting clinical scenario is the patient with chronic kidney disease, particularly those on hemodialysis. And we described in a cohort of 85 screened hemodialysis patients a very high prevalence of high on Clopidogrel platelet reactivity, up to 82%. In this population, we also showed that Pragugrel is more effective than double Clopidogrel. Doubling Clopidogrel doesn't do anything. And also, very recently, we published our experience, the first experience in hemodialysis patients with hyporesponsiveness to Clopidogrel, in which we gave Ticagrelor, and it was very effective in almost all of the cases. In conclusion, Mr. Chairman, hyporesponsiveness to Clopidogrel can be identified and can be treated, particularly with the use of the new antiplatelet agents, Pragugrel and Ticagrelor. However, there are several question marks about which patient actually has to have this test done and treat the high platelet reactivity if it is present. Thank you for your attention.